You're watching RISKSA TV. I'm joined in studio now by Dr. Maurice Goodman, Chief Medical Officer at Discovery Health. Thank you for joining us, Dr. Goodman. We've been talking a little bit earlier today about the fact that there's traditionally, kind of all around the world, there's a tension between those who fund medical practice and those who practice it. And it kind of exists within any system. Why does Discovery feel like it's really important to bridge across that and build collaboration and trust?
Yeah, thanks. So, as we were discussing, we believe that within a healthcare system, different players bring different skills and benefits to the system. The doctors, particularly in this country, we're very privileged to have an excellent set of doctors, both GPs and specialists, and they're really world-class in terms of their knowledge of medicine and their treatment of a patient. What they don't have is a macro view of the healthcare system. We do have that view. We sit on a lot of data, information, literally billions of lines of claims data and other healthcare information that's coming into the system. We can understand that, we can analyze that, and we can feed that back to the doctors in a very collaborative way that enables them to practice medicine. So we really believe that there's a kind of virtuous cycle. It's a team sport. And rather than there being conflict and tension in the system, we believe we should each play to our strengths. We can collaborate, and there are a number of examples of how we've been doing that over a number of years, old examples, new examples, and really that brings out the best in both of us and the best for the system as a whole.
Currently, how are you doing that in practical terms? What are some of the platforms and structures that enable you to do that?
So we've had a program that's been running, for example, with a number of years with the pediatricians via the pediatric management group, whereby we feed back to that group information about their admission profiles, the way they treating and managing different patients, and under the auspices of their society, those pediatricians then are able to analyze the admission patterns, the other ways that they're treating their patients, and we've demonstrated in the system that's resulted in better quality of care for their patients and lower cost in the system. A very interesting example that we've just launched really with a group, a network of GPs, we're calling Premier Practice. And what we're doing there is we've packaged all the wellness information and the wellness science that we've developed through our years of our Vitality program. And we're making it easy now for doctors, for those GPs, to actually prescribe a wellness package to their members who are living with various chronic illnesses, diabetes, hypertension, etc. So that's examples of how we are able to take our experience, the actuarial knowledge that vests in Discovery, and present that back to the doctors in a way that enables them to give better care to their patients. Because ultimately what unites us, and that's what we should focus on, what unites us rather than what separates us. What unites us is a joint commitment to improved patient care.
So on that topic of the tension between funders and practitioners, there's been this long-running debate and tension around prescribed minimum benefits in the country. And we've had the announcement just recently from the Minister of Health that Regulation 8 in the Medical Schemes Act, it looks like it will be altered, and that it's not entirely clear yet, but that it will mean that medical schemes won't be responsible necessarily for paying the full amount, regardless of what that is, from medical practitioners. What is Discovery's take around that? And I'd be particularly interested in also, I know that the Board of Healthcare Funders has come out in support of this announcement, and I think there is still a question really of how is this ultimately going to benefit patients, really?
Thank you. As you say, it is a very topical issue. The first point to realize, though, that this is a draft regulation that's come out. There's at least 3 months now that is allowed for comment, and there already has been, and there certainly will be lots more comment. So It's a bit of speculation at the moment because it's important to note that this certainly isn't a final regulation yet. However, having said that, as you mentioned, the prescribed minimum benefits puts in place funding that funders need to provide in full for a range of conditions. What the legislation also makes allowance for is so-called DSPs, or designated service providers. So what all medical schemes have done is come up with financial funding arrangements with groups of doctors who will provide cover for these prescribed minimum benefits at an agreed rate. If patients go out of those DSPs, if they do so voluntarily, then there may be a co-payment for which the patient is then liable. If they go out of the DSP involuntarily, that's typically an emergency situation, then the medical scheme needs to fund, under the current legislation, whatever is charged by the doctor. And so there's the risk for the medical scheme, a kind of open-ended funding obligation. What this modification of the regulation seems to do is limit now the medical scheme's obligation to the NHRPL 2006 plus CPI increases. So that gives you a number, and it would appear that the medical scheme's obligation is limited to that, so it won't be an open-ended obligation anymore. What's not clear is, what does that mean for the doctors? The one interpretation is that the doctor's still open to set his or her rate, whatever that may be, and in that case the patient then would be left with a shortfall. From Discovery's point of view, obviously we will comment and we will contribute. However, this is really a non-event for the vast majority of our members. We do have in place, both with specialists and with general practitioners, a range of payment arrangements and networks whereby over 90% of all the interactions between our members and the GPs or the specialists are covered in terms of the payment arrangements, which already pays multiples of this so-called base rate, the NHRPL by CPI increase. Our payment arrangements with these doctors is already significantly above that, and it, as I say, it caters for well over 90% of those interactions. So from our perspective, it really won't impact significantly the members of any of the schemes that we administer.
Perfect.
Good.
Thank you so much for your
Thank
time
you.
today.
Thanks very much.